We'll begin with the first topic, and for that, I would like to call upon the chairperson, Dr. Shweta, who's the consultant physician and diabetologist at Amaze Clinic, Bengaluru, who's the founder of Sweet U-Turn. We welcome you on stage, ma'am.
Very good morning, and very happy to chair the first session, and I'm so happy to honored to introduce Dr. Sanjay Dash, from a consultant physician, and he's from Talshar, Odisha. He has been a honorary advisor of research and real-world evidence, Sigma Mosaic Solutions, chairman of RSSDI Odisha, founder member of RSSDI Odisha, and invited speaker at various, I won't even be able to list all of them, various such stages, contributed chapters in ICP Monogram and postgraduate medical updates 2017 to 2022. His areas of interest are something that really intrigues me. One is infectious diseases, non-communicable disease, and of course, artificial intelligence in medicine, a very interesting one. I'm so happy that the stage is yours, sir. And the topic is TZDs, the cardiovascular risk and beyond insulin resistance. The stage is yours, sir.
I think we should not do any conjugacy in claps. So let's welcome the speakers and chairperson with a big round of applause.
So thank you, Chairperson Madam. Thank you, Dr. LSM, for inviting me to this August gathering. So I'll be speaking about a topic which is not a blockbuster drug. We know there are two blockbuster drugs, SGLT2 inhibitor and GLP-1 RA. Amongst these, there is a drug which is not a legacy drug, but this is there in our clinic in the shelf. We are not using it so often. And in the next 18 minutes of this Saturday morning, I'm going to tell you why this is a very important drug as far as the metabolic protection is concerned for our day-to-day practice. So my topic is TZDs or glitazones, moving beyond insulin resistance and cardiovascular risks. We all know glitazones are the only insulin sensitizers that address the root cause of type 2 diabetes, that is insulin resistance and lipotoxicity. How it does? It increases the insulin sensitivity by acting on adipose, muscle, and to a lesser extent in the liver to increase glucose utilization and decrease glucose production. So today I'm going to discuss the shift, moving the conversation from fluid retention, which is why we are not using it so often, to multi-organ protection. So the agenda is clinical paradox. Why a black box drug like pioglitazone remains a gold standard for metabolic health, the adipose liver axis, how it helps addressing the MASH and the ectopic fat problem, the neurological frontier, decoupling stroke prevention from glucose lowering in non-diabetic patients, macrovascular truths, re-examining the proactive data from a modern lens, and the safety 2.0 strategy, risk stratification, and the 15 milligram sweet spot, because we know if you increase the dose to 30 or 45 milligram, there are lots of side effects. Then the triple therapy synergy, integrating TZs with SGLT2 inhibitor and GLP-1 RA. So the part setting the context. Why talk about glitazones again? We all know, despite these two blockbuster drugs, metabolic disease burden persists. The key unmet needs are the MASLD, MASH, residual CV risk, and progressive beta cell failure. Glitazones affect multiple pathophysiological pathways. How it does? It influences several metabolic systems like adipose tissue biology, inflammation, lipid metabolism, vascular endothelium, hepatic steatosis, beta cell preservation. And these all are done through a novel nuclear receptor known as PPAR, which is activated. PPAR gamma and alpha is activated by this particular molecule. Pleiotropic biology. So, friends, glitazones actually activate these PPAR gamma receptors, which are mainly found in the nucleus of certain cells, mainly the adipose tissue, beta cells, endothelium, macrophages, and CNS. Besides, of course, in vascular system also. PPAR gamma affects genes in glucose and lipid metabolism. It increases the gene expression for lipid storage in adipocytes. It converts the bad visceral fat, which is very much toxic and pathologic, to metabolic healthier subcutaneous fat. So it shifts. How it does? Through adiponectin. Glucagon also reduces the genes expression linked to inflammation like IL-6, CRP, so many other inflammatory responses are there. How it does this? There is insulin sensitization effect. The activated PPAR gamma boosts adiponectin, which is an anti-inflammatory insulin sensitization good hormone, which makes fat tissue beneficial for metabolic health, taking out from the visceral fat like the liver or the omentum to subcutaneous fat. PPAR gamma activation in CNS helps in neurological protection, but it also causes weight gain. But of course, the weight gain is because of more of the fluid retention. So these all glutagones reduce many inflammatory markers like TNF-alpha, IL-6, CRP, macrophage infiltration in adipose tissue. This mechanism links glutagones to vascular protection. This activation also improves the vascular health by nitric oxide availability increasing, by improving the endothelial function and decreasing the oxidative stress. This all lead to anti-atherosclerotic effects. So what are the organ-specific benefits? Please remember, I am not talking about type 2 diabetes. I am only talking about the metabolic health. So the landmark trial, which was published in New England Journal of Medicine in 2010, the PVENS trial, it was without diabetes, but with biopsy confirmed NASH, and 247 people were included in this survey, in this trial, and they were given pioglitazone in one arm, in another arm was vitamin E, and in the third arm was placebo. Please remember there were two drugs, pioglitazone and vitamin D. So it was more or less for 2 years study, and the composite endpoint was resolution of NASH, which was very important for this. The primary outcome, only 34%. Please remember, 34% of the patients actually achieved the endpoint versus 19%. This is good. But did it actually achieve the p-value? No, this did not achieve the p-value. Whereas in vitamin E, 43% achieved the endpoint, which was achieving the p-value. Effect of steatosis and ALT and other insulin sensitivity increased markedly, but there was weight gain of 2 to 4 kg. And fibrosis change, none of these drugs, both the drugs actually helped in changing the fibrosis in this particular trial. So the strongest metabolic effect outside glycemia has come from PVENS trial. It improves the steatohepatitis, reduced hepatic fat, improved histology. But there was a technical miss. What was the technical miss? It did not actually achieve the p-value. Please remember, though it did not achieve the p-value, the reason was it was a very stiff p-value. And why it was a very stiff p-value? Because there were two drugs. Instead of one drug versus placebo, there were two drugs. So because there were two drugs, the p-value was kept very stiff. Though this p-value clinically effective at reversing the disease, it was clinically effective, but did not achieve the p-value. There are other trials like the Kusi trial at 2016. Then recently there was in Chinese meta-analysis in 2022. Some were diabetic, some were non-diabetic. Some included both diabetes and non-diabetic. Mostly the trial included 30 milligram or 45 milligram of pioglitazone, and there was significant impact on ALT and AST in all these trials. And steatosis also improved significantly in most of these. Histological NASH resolution was also achieved in most of these trials, but fibrosis was not much improved in any of this, except trend was there towards improvement. Only in Kusi et al. There was significant improvement in fibrosis score. Metabolic effects, improved insulin sensitivity, improved insulin sensitivity in almost all trials, but weight change was there. All of these actually increase the weight. Next, I come over to another trial, which was IRIS trial, which focused on non-diabetic, strongly insulin-resistant patients who had prior neurological, either stroke, ischemic stroke, or TIA. So these were the patients in which 5 years trial, it was roughly 5 years trial, and what they found? This was pioglitazone 30 to 45 milligram titrated and placebo. It was covered for 5 years, and they found 24% relative risk reduction compared to placebo. In what? In composite of fatal or non-fatal stroke or fatal or non-fatal MI. Primary endpoint was achieved. There was another very important diabetes prevention was there. 52% reduction of diabetes in this strong, very severe insulin resistance. But here also there were two very important side effect adverse reaction in 45 milligram of pioglitazone. Weight was more in pioglitazone group, and fractures were there mostly in postmenopausal ladies. Distal limb fractures were there, which was very important in this. Heart failure was not there. Heart failure was not significant in both the arms. So what it proved? It proved that vascular protection with this particular drug prevents recurrent strokes and heart attacks, and this is a disease modifier. It converts pre-diabetes to normal healthy, or it remains like that. It does not convert pre-diabetes to diabetes in 52% of the person, and HOMA-IR is the target in this because the HOMA-IR was more than 3. Resistance, this insulin resistance is itself was the target, and what was the mechanism for this CNS improvement? It was mostly anti-atherosclerotic and anti-inflammatory. So now move on to the vascular, atherosclerotic cardiovascular disease vascular trial. The most important trial was proactive trial, which was there for 3 years. It was there for 3 years, and most of these were type 2 diabetes who had prior ASCVD event, MI, stroke, or peripheral arterial disease. Please remember, peripheral arterial disease was included in this, including bypass surgery and surgery for the peripheral vascular disease. This was the primary endpoint, surgery for this, and the secondary endpoint was MACE endpoint, composite of all-cause mortality, non-fatal MI, and stroke. What was the primary outcome? Not much significant. Only 10% was the primary outcome. Secondary outcome was significant, 16% relative risk reduction, which was highly significant. Please remember, in this, what we found? We found weight gain, we found fluid overload, we found heart failure incidence was quite serious. 6% versus in placebo was 4%. These severe heart failure cases were hospitalized. Lipid profile, there was improvement in lipid profile of triglyceride and HDL, and LDL was neutral or a little bit low, a little bit increased. Safety signals, weight gain was of course there, and peripheral edema was more common. So what, friends, evidence for a proactive trial shows? It shows key findings, secondary composite endpoint, decreased death, MI, and decreased stroke. So if I summarize the big 3 trials, in the PVENS population was NASH, 34% NASH resolution, potent histological benefit in the liver. If you see in macrovascular prevention, proactive, 16% reduction in MACE proves secondary macrovascular prevention. In IRIS, there was 24% reduction in stroke, re-stroke, and myocardial infarction. There is direct neuro and cardiovascular protection. So, in other Periscope study and Chicago study, pioglitazone is shown to reduce carotid intima media thickness, stabilizes the plaques, decreases coronary and vascular inflammation, and improves endothelial function. The net result is direct vascular benefit. So, metabolic effect beyond glucose, as I have told, pioglitazone reduces triglyceride, increases HDL, and favorable LDL particle size shift from small dense to a little bit better LDL particles are converted from small dense to better LDL particles. So these chains are atheroprotective. Glitazones also reduce glucotoxicity, reduce lipotoxicity, preserve beta cell function. This may slow diabetes progression. Now, what are the risks and controversy? Why this was given black box, which is no more there? The black box is only for heart failure now. There are the major limitations: weight gain, edema, heart failure risk, and fractures. Careful patient selection is very important for all of us. But whether these CV risks are overstated, please remember this fluid retention, which actually causes, increases heart failure. There is no heart failure, contractility is not actually involved in this. This heart failure hospitalization is versus atherosclerotic events which are decreased 16%. So this is an important distinction between heart failure risk versus MACE reduction. So now the clinical relevance today, where we can use this pioglitazone, which is the only drug available in our country. The ideal patients are severe insulin resistance, MASLD and MASH, pre-diabetes, high residual CV risk, IR stroke patients, and type 2 diabetic patient needing durable long-term control. You know, this is a particular molecule which has got effect for more than 5 years. Sulfonylureas or other drugs and newer drugs don't have this much of strong benefit for more than 5 years. So complementing modern therapies, best strategy is combine SGLT2 inhibitor and TZDs, offsets the fluid retention, combine with GLP-1RA, offsets the weight gain, providing multi-pathway metabolic control. So the big three of organ protection, as you all know, glitazone's gold standard for liver, GLP-1s are actually gold standard for weight loss, ASCVD, and it is neutral for heart failure. Glitazones are bad for heart failure. SGLT2 inhibitors are good for heart failure and renal protection. Durability best is glitazones. So precision use of pioglitazone, avoid in advanced heart failure in NYHA stage 3 and 4, severe osteoporosis, significant edema. If you see, if you are giving 15 milligram versus 45 milligram, insulin sensitivity increases to the right. If you are, it is more with 45 milligram. Mass benefit is also evidence proven, more with 45 milligram. Stroke prevention also IRIS says more with, strong with 45 milligram. Side effect burden is also more with the 45 milligram. So what we should do? The sweet pill is 15 milligram. The 15 milligram sweet spot and safety 2.0, the domain is hepatic. Liver histology benefit are now being explored with 15 milligram. Because 15 milligram adverse weight gain is less, brain, if you are giving 45 milligram, edema and weight gain is more. If you are giving it less, then there are chances that this won't be there. Cardiovascular outcome trial has shown that adverse reaction happens with more doses, increased doses, and less with reduced doses. So the 15 milligram sweet spot and safety 2.0, bladder cancer. Now it has been debunked in the last more than 1 million patients, retrospective trials studies were done. The KP study was also done, and this is only 6%. And mostly these patients, type 2 diabetes, were searched for this bladder cancer. That is why it was found. So what we should do, if somebody has definite bladder cancer, or they are having macroscopic hematuria, we should not give this to them. Bone health, of course, 2 times more common, with mostly for osteoporotic elderly ladies. We should not give this to those people. Otherwise, we can give. Heart failure is very important for us to know. 40% more with this particular drug. This is but fluid related, not cardiotoxic. Weight gain and edema is mostly with higher dose. With lower dose, it is not there. So friends, 15 milligram is metabolic modulator, which is safe for chronic use. 30 milligram is actually balanced efficacy. 45 milligram is actually trial grade outcome. All trials with 45 milligram only. So the take home messages are, glitazones do far more than improve the insulin resistance. They influence inflammation, adipose biology, and vascular disease. Evidence supports benefits in MASH, stroke prevention, and atherosclerosis. Appropriate patient selection is very critical for us. So the key take-home message, friends, pioglitazone is more than a glucose-lowering agent. It's a multi-system disease modifier. It treats the liver, MASH resolution, the vessel, MACE reduction, and the metabolism, diabetes prevention simultaneously. By using a low-dose initiation strategy, we can capture these pleiotropic benefits while maintaining an excellent safety profile. I have not talked about PCOS, I have not talked about Alzheimer's disease and Parkinsonism, in which these drugs are actually beneficial, but these are not these are off-label use, so I am not discussing about those things. Thank you very much.
Thank you. Thank you so much, sir.
Did I overshoot the time? Or
No,
I
sir,
was
not
in
at all.
time?
You still have 2 minutes. I think we can have 1 or 2 questions. From black box drug to a 15 milligram sweet spot or being a multi-system disease modifier, every word was enlightening and a reminder. Thank you so much. And if there are 1 or 2 questions, we can definitely take it up since exactly 1 minute is there. Yeah, there is a question.
For wonderful talk, sir. You talked about the low dose, 15 milligram. Have you ever using 30 milligram in your clinical practice, or what about 7.5 milligram, which is not available in market? Would you recommend 7.5 milligram, or you stick to with 15 milligram?
I give 15 milligram. If your evidence says 45 milligram is the one which is going to help. But we in our country are giving 15 milligram to start with. Then we are going till 30 milligram. It's a combination with drug. 15 milligram, 30. And as you know, GLP-1 RA is coming, but SGLT2 inhibitor and pioglitazone is already there in the market, combination of this. So we are using a lot of these, and they are showing benefit to the patients.
Thank you very much.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, madam.
Thank you to the speaker and chairpersons. We would request you to move towards the selfie area, which is just outside the hall, to collect the memento.